about a very important topic for exams. Almost always there is one question from this topic. So that is management of solitary thyroid nodule. Very, very important, and lots of questions are there from this topic. Okay, so management of solitary thyroid nodule. So we'll see this, and then I'll talk about something very important about the DAMS Live app, the features of DAMS Live app, and how it is beneficial. So we'll talk about that. So first I'll tell you about solitary thyroid nodule. Solitary thyroid nodule management. Okay, very, very important. One of the most important topics of thyroid, solitary thyroid nodule. Okay, so first we'll see what is the meaning of solitary thyroid nodule. Okay, solitary thyroid nodule is a palpable abnormality in the thyroid gland which is otherwise normal thyroid gland. Okay, suppose this is a nodule. So when the patient comes to the OPD, patient does not have any, the main problem of the patient is that there is a swelling in the neck. So this is how the patient will come in the OPD. Patient will come and they'll say, or she will say, that there is a swelling in the neck, and when you examine the swelling you will find that this is actually arising from the thyroid gland, okay, based on the very classical history of movement with the deglutition. Okay, so a abnormal nodule, a single nodule in an otherwise normal thyroid gland is solitary thyroid nodule. This is solitary thyroid nodule. So what we are going to do when the patient comes with solitary thyroid nodule. Okay, so the patient comes, first thing is like what we do in otherwise any patient, any surgical patient when comes, we will take history and clinical examination. History and clinical examination. Those who are like who are going to give their final prof exam, this is a very important theory question also. Okay, management of solitary thyroid nodule. This will be a long question, and if you write the question like how I am going to tell you, then you will get the maximum marks there. Okay, so history and clinical examination. After in history you will ask all the histories like history related to hypothyroid, hyperthyroid, history related to any thyroid malignancies in the family. So all that is important history of irradiation in the past. So those are the important history, and clinically you will examine what is the size of the nodule, whether it is arising from the thyroid or it is arising from somewhere else. Okay, the consistency. So all these things you will examine, the neck nodes also, the cervical lymph nodes. Okay, so these things you will do when the patient comes to the OPD. History and clinical examination will be the first thing. After that, question comes that what is the first investigation in case of solitary thyroid nodule? Okay, that is the question. First investigation in solitary thyroid nodule, you will go for thyroid profile, T3, T4 and TSH. Okay, so you will do this will be the first investigation. This is MCQ. Okay, first investigation in solitary thyroid nodule is T3, T4, TSH. So when you get the result of this T3, T4, TSH, you can have two types of results. Either the patient is hyperthyroid, that means decreased TSH. Okay, so I'll write hyperthyroid, or the patient could have a normal TSH or normal thyroid profile, that is euthyroid, that is normal TSH, or hypothyroid, that is increased TSH. Okay, so you'll have two types of patient in two arms, either a hyperthyroid patient or a eu or hypothyroid. Now first see what we do in these patients, what we are going to do for these patients who are hyperthyroid or where the TSH is low. Okay, is it still there is echo or the voice is clear? Okay, so in these patients where there is hyperthyroid, the next investigation will be a radioiodine scan or thyroid scan. Radioiodine scan, also known as thyroid scan. Okay, so there is role of radioiodine scan only in these group. Okay, when the patient is hyperthyroid. In case of euthyroid and hypothyroid, there is no role of radioiodine scan. Okay, so if this is the case, you get a radioiodine scan. In the radioiodine scan, what we do is we'll give isotopes like iodine 123, iodine 131, or technetium 99 pertechnate. These are the radioisotopes. Theoretically speaking, iodine 123 is most commonly used, but practically in India we don't get iodine 123, we get iodine 131. So in India what we do is iodine 131 is mainly used for the therapeutic purpose, for ablation. But here we use iodine 131 in very low doses for diagnostic purpose also. Okay, so 131 can be used both for diagnostic as well as therapeutic purpose. Iodine 123 and technetium are only diagnostic. Okay, so theoretically the most important is iodine 123. So these radioisotopes, they come in the form of a capsule. Okay, you ask the patient to swallow a capsule, patient takes that capsule, and then you take that iodine 123, it releases in the body, and the thyroid gland will take up that iodine 123. Now you will call the patient after 1 hour, 2 hours, 4 hours, and you will see how is the uptake in the thyroid gland. Okay, how is the uptake of this radioisotope in the thyroid gland. So see, suppose this is thyroid and this is that nodule. Okay, so there are three possibilities after the radioiodine scan. Okay, there are three possibilities. This is, suppose this is that nodule. In one case, in the first case, what can happen is that majority of the radioisotope is taken up by the nodule. Okay, and the gland has taken very less or almost nothing. So that type of nodule is known as hot nodule. Hot nodule. In the second case, the nodule has taken as well as the gland has taken almost equally. Okay, nodule and gland, they have taken almost equally. That will be known as warm nodule. Warm nodule. And in the third case, what can happen? The gland has taken the isotope nicely, but the nodule has not taken. Okay, so that will be a cold nodule. That will be a cold nodule. Okay, so these are the possibilities: hot, warm, and cold. Okay, so actually how does it look? I'll show you. Okay, see this is the solitary thyroid nodule. If you can make out, this is the swelling. This is that swelling in an otherwise normal. The rest of the gland is normal, only one nodule is there. Now see this picture. This is cold nodule, what the pointer is showing. Okay, the gland has taken, but this area, this has not taken. The nodule has not taken. So that is known as cold nodule. Just see these, the other part. The gland has taken very less, and the nodule has taken most of the radioisotope. So that is hot nodule. Okay, so just see cold and hot, don't see the other things. So that is cold nodule and that is hot nodule. You can see in this picture, this is hot and this is cold. Okay, so this is hot and cold. So this is how you will see on a radioisotope scan. Okay, so previously these radioisotope scans was also used to basically for malignancy also they were using, but now we don't use for the diagnosis of malignancy. In malignancy we use this as a we can say the radioisotope scan is used in the follow-up period to see the residual tumor. But if we talk about the risk of malignancy in hot nodule, that is minimal. You can say around 1% risk of malignancy. In case of warm nodule, you can say approximately 1 to 5%. In cold nodule, it will be around 15 to 18, or you can say 20%. So although the risk of malignancy is more in cold nodule, but as you can see, most of the cold nodules are also benign. So just on the basis of this radioisotope scan, we cannot say that this is malignancy, or we cannot say that this is not a malignancy. Okay, so that's why it is not used for the diagnosis anymore. It is used for the follow-up. So hot nodule, warm or cold nodule, this is what you are going to get after a radioisotope scan. Now if you get this finding, if you get a hot nodule, then the next step if you get a hot nodule is give antithyroid drugs. Give antithyroid drugs, and you have to give these drugs for 6 months. Okay, so give antithyroid drugs for 6 months if you are getting a hot nodule. But if the finding is this warm and cold, if you get this warm and cold, then the next step will be the same as what you do for euthyroid or hypothyroid. So I will say that these patients will be treated as we treat a euthyroid or hypothyroid. Okay, so these will be treated as we treat a euthyroid or hypothyroid. So now we'll come to our second arm, that is euthyroid, hypothyroid, or we can say now we can add cold or warm of hyper. Cold or warm of hyper. Okay, so this is another arm or another group. Now see what we do in these cases. In these cases, radioiodine scan is not done. What we do is, the first thing we'll do is, we'll get a ultrasound neck. We'll get a ultrasound neck. Okay, so when we do a ultrasound will tell you the size of the nodule, the exact size. Like clinically, you might find it 2 cm on ultrasound, it might be 2.5 or 1.5. So it will give you the exact size. So the cutoff value which we take when we do the ultrasound is 1 cm. More than 1 cm or less than 1 cm. Now this is important. This value, remember this value of 1 cm, it is for those nodules. Ultrasound will also tell you that this is a solid nodule, a cystic nodule, or a spongiform nodule. Okay, so 1 cm is the cutoff. Okay, I'll write cutoff is 1 cm for a solid nodule. Okay, and if it is a solid plus cystic, then it will be 1.5 cm. 1.5 cm for solid and cystic. Means if the component is partially cystic, partially solid, then we'll say less than 1 cm and more than 1.5. I mean less than 1.5 and more than 1.5. And it will be 2 cm if it is a spongiform nodule. Spongiform. And if it is a cystic nodule, totally cystic, then we will not consider any FNAC. Okay, I'll write no FNAC. So why I am telling you this is because if the nodule size is less than 1 cm, then we'll do follow-up. Follow-up means we'll call the patient again after a few months and do the investigations again. But if it is more than or equal to 1 cm, then we'll go for FNAC. Okay, so just see the size criteria here. For solid 1 cm, for solid plus cystic 1.5, for spongiform 2, and for cystic there is no need of any FNAC. Okay, and this FNAC, fine needle aspiration cytology, this is the investigation of choice. This is another very important question. What is the investigation of choice? Okay, so it might not be the first investigation, but this is the investigation of choice for solitary thyroid nodule, FNAC, fine needle aspiration cytology. The size of the needle, 23 gauge or 27 gauge, these are the size of the needle we use for fine needle aspiration cytology. Okay, so remember when to go for FNAC in case of solitary thyroid nodule, and FNAC is the investigation of choice. Now see, those patients who are less than 1 cm or less than that cutoff, we can say this is the cutoff, less than this size where we are going for follow-up, if there is lymph node enlargement in the neck. Topic is solitary thyroid nodule. Topic is management of solitary thyroid nodule. I'll repeat after finishing it again. Okay, so if the patient is having enlarged lymph node in the neck, if there is family history of thyroid cancer, family history, or maybe we can say personal history also, because these days many times we do hemithyroidectomy, then the remaining lobe which we have left behind, if there is a nodule, that means there is personal history also. Or if there is history of prior irradiation. Now when we talk about irradiation, this is the therapeutic irradiation, not the X-rays or CTs. We talk about therapeutic irradiation, like patient had Hodgkin's lymphoma in the past and now that time she had received some radiation. Okay, so if any of these is there, any of these, then in these cases, these are the high risk cases. In these cases also we'll go for FNAC. Okay, if any of these features are present, then again despite less size we'll still go for FNAC because these are the high risk features. Okay, so now we'll see. Okay, voice, I don't know, echo is having problem. Okay, so when we do FNAC, now FNAC will give us different findings. Okay, different findings, and the findings could be non-diagnostic. Okay, FNAC report comes and they will say that they could not find out any pathology, non-diagnostic. Second we can get is that this is a benign swelling. Third thing, we get a finding which is known as atypia of unknown significance or follicular lesion of unknown significance. Okay, atypia of unknown significance or follicular lesion of unknown significance. Fourth, we can get a finding where they will say that this is follicular neoplasm. Okay, follicular neoplasm. They will not tell that this is a adenoma or carcinoma. They will just tell this is a follicular neoplasm. Or we can have a finding where they will say it is a malignancy, confirmatory of malignancy, or highly suspicious of malignancy. Highly suspicious of malignancy. Okay, these could be different findings. And there is in pathology, there is a classification system based on these findings that is known as Bethesda classification. So according to Bethesda classification, these are the these 6 findings you can get in the after the FNAC. Okay, so I'll just tell you again, solitary thyroid nodule is a single palpable abnormality. First investigation is T3, T4, TSH. If there is hyperthyroid, that is decreased TSH, we'll get a radioisotope scan, radioiodine scan, iodine 123, 131 or technetium 99. Hot nodule, warm and cold, these are the different possibilities. If it is a hot nodule, go for antithyroid drugs. If it is warm and cold, then treat it like you treat a euthyroid or hypothyroid patient. In that, you will go for a ultrasound neck as the first investigation. Now there are certain findings suggestive of cancer, features suggestive of malignancy on ultrasound. Okay, features suggestive of malignancy is the first very important thing is hypoechoic. Hypoechoic means the nodule will look more black as compared to the rest of the gland. Okay, hypoechoic. Then taller than wide. I'll show you the images also. Taller than wide. Microcalcifications like what we see in mammography in breast cancer. In thyroid also microcalcifications are suggestive of malignancy. Increased vascularity. And one more finding is when there is asymmetric thickening or when there is architectural distortion. Asymmetry or architectural distortion. Okay, so these are the findings. These findings are suggestive of malignancy on ultrasound. Okay, suggestive of, not confirmatory. These days, based on these findings, there is a scoring system also which is known as TIRADS, like Thyroid Imaging Reporting and Data System. It is based on these 5, we can say, features. Thyroid Imaging Reporting and Data System. You don't need details of these TIRADS. Okay, but this is like BIRADS you need to know in detail. TIRADS is okay, if you know, that is fine, TIRADS. Okay, so let me show you some images. See, this is the ultrasound and this is the nodule. This is hypoechoic. Okay, this is hypoechoic. Which is hypoechoic is a feature of malignancy. See, this is isoechoic. Okay, so this is not malignancy. This is isoechoic. This is not malignancy. This is hypoechoic. This could be cancer. And if you can see this lesion, this is taller than wide. Okay, so this is more taller. This is taller than wide. Again, this is a feature of malignancy. A nodule which is taller than wide is a feature of malignancy. Another I'll show you, there is if it is wider than tall, then it is not in the favor of malignancy. Okay, taller than wide. So taller than wide, hypoechoic, asymmetry, microcalcifications. See, based on that there is this thyroid score. Thyroid score, and based on that thyroid score we can say again benign or suspicious or highly suspicious. Okay, so that is thyroid score. Okay, so after ultrasound, depending on the size, we will go for FNAC or we can follow up. So size criteria I told you. FNAC will give you these features. So Bethesda classification, non-diagnostic, benign, ATP of unknown significance, follicular lesion of unknown significance, follicular neoplasm, highly suspicious, or confirmatory of malignancy. There is one more classification which is known as, that is a European classification. They write this as Thigh 1. Benign will be Thigh 2. This will be Thigh 3A. This will be Thigh 3F. This will be Thigh 4. This will be Thigh 5. So that is another classification, that is you can say Thigh classification. This is a European classification. Bethesda is, they have given these names, and in Thigh classification they have given these like the coding Thigh 1, 2, 3A, 3F. Okay, so these are the different findings you will get after FNAC. Now we'll see what to do next. If it is non-diagnostic, then we'll repeat FNAC and preferably ultrasound guided. Okay, this time we'll be more specific. With the help of ultrasound, we'll put the needle under vision into the nodule and we'll take the FNAC. Okay, if it is benign, we will follow up. Okay, there is no need of surgery, we will follow up the patient. If it is ATP of unknown significance or follicular lesion of unknown significance, now what to do in these cases? We have different options. We can either follow up or we can repeat FNAC. And these days there is something known as molecular markers. Okay, so we can go for these molecular markers also if we get a finding of ATP of unknown significance or follicular lesion of unknown significance. Now, what are these molecular markers? This is, they have not asked question on molecular markers yet, but this is important upcoming thing, so there are chances that you'll get a question on this molecular markers. Molecular markers can be genetic, immunocytogenic, or immunochemical immunocytogenic, or epigenetic. Genetic, immunocytogenic, or epigenetic. These are the molecular markers. Now in genetic markers, we'll have mutations, we'll see mutations like BRAF mutation. BRAF mutation is seen in papillary thyroid cancer, RAS mutation, RET mutation, P53. Okay, so these mutations we'll see. I'll just write this we'll see in papillary thyroid. This is follicular thyroid cancer. RET we all know it is seen in medullary thyroid cancer. P53 will be seen in anaplastic thyroid cancer. Okay, so we can see these mutations, genetic, that is molecular marker. In immunogenetic, we have other things like galactin 3, HbME1, then cytokeratin. There are different types of cytokeratin, we'll see, and vascular endothelial growth factor. So these are the immunocytogenic markers we'll see. So in this galactin 3 will be seen in both papillary thyroid cancer and follicular thyroid cancer. HbME1 suggestive of papillary thyroid cancer. Cytokeratin 19 is suggestive of papillary thyroid cancer, and if it is 7 or 18, medullary thyroid cancer. This will tell lymph node metastasis. Okay, so these are the things, these are the molecular markers. Epigenetic is not that important. Epigenetic will see DNA methylation or microRNA. So these things are, these are the upcoming things in the management of solitary thyroid nodules, these molecular markers. Okay, and these are the markers. Just you should have just a brief idea, not very deep into this, just a brief idea about what are the molecular markers and what is the role of this, role in ATP of unknown significance and follicular lesion of unknown significance. So these are the options. We can go for either of these depending on the availability in that institute. Now, if it is a malignancy or a highly suspicious of malignancy, in these cases we will go for surgery. We will go for definitive surgery. Definitive surgery, which could be most of the times total thyroidectomy, and at times if the features, if it is a low risk cancer, like when the age is favorable, the grade is low, well differentiated, size is also less than 4 centimeters. So in those low risk features, we can go for hemithyroidectomy also. But this is a definitive surgery because we know the diagnosis beforehand. Definitive surgery, total or hemi. Now we are left with only one. That is, what if it is a follicular neoplasm, that is Phi3F, because we all know follicular adenoma or follicular carcinoma cannot be differentiated on FNAC. FNAC will tell you this is follicular neoplasm, whether it is carcinoma or adenoma, that is not, that finding you will not get on FNAC. So now what is next? Next we'll go for a hemithyroidectomy. Okay, we'll go for a hemithyroidectomy if it is a follicular neoplasm. And remember, this is the minimum biopsy in case of thyroid cases. There is nothing less than hemithyroidectomy for a diagnostic purpose, like apart from FNAC. If FNAC is not helping you, minimum biopsy is hemithyroidectomy. So when you do a hemithyroidectomy, half of the, you can say the gland along with the isthmus, you will send it for histopathology examination. Previously on FNAC you have sent few cells. Now you are sending the whole, you can say the nodule along with the half of the gland. So histopathological examination, what they do is they will check for vascular and capsular invasion. Vascular invasion and capsular invasion. So if vascular and capsular invasion is present, it means it is follicular carcinoma. And if it is absent, it is follicular adenoma. Okay, so follicular adenoma is a benign, we can say, condition. So here we don't have to do anything else. Follicular adenoma, the maximum we do is hemithyroidectomy, that we have already done. Okay, so no further treatment. No further treatment. But if it is a follicular carcinoma, then we have to call the patient again and do a completion thyroidectomy. The part of the thyroid which we had left, call the patient again and do a completion thyroidectomy. Okay, so this is the management of solitary thyroid nodule. This is the management of solitary thyroid nodule. I'll show you the few images also. So I hope you understand this is a very, very important topic, and there are lots of new things are also coming in this. So this is one of the most important topic in case of thyroid. And thyroid, we all know, is very important for any exam, for your theory exam, for your MCQ exams, NEET, INI-CET, all exams. This is one of the very, very important topics. I hope it is clear. If you have any doubt, you can ask me. I'll show you some images also related to that. Okay, so just see when we do a surgery, when we do a hemithyroidectomy, suppose this is the nodule, they have marked the nodule, and now we'll give the incision. This is the classical incision for a thyroidectomy. For hemithyroidectomy, the incision is slightly low, slightly, we can say, smaller as compared to total. So this is the incision. First we cut the skin, the subcutaneous fat, and then you cut the platysma, very thin muscle in the neck, and then you separate you can retract the strap muscles, and you can see the thyroid. Now you can see here the nodule, you can see here, and now the surgery is done. They are ligating the vessels individually. We don't ligate the main trunk of superior and inferior thyroid artery, we ligate the vessels individually, and then this is the surgery done. You can see here, this is the trachea. So the part of the nodule along with the isthmus we have removed, and after the closure we put a drain so that if there is any hematoma which forms, it should come out. It will not cause any breathing problem. Okay, important aspects which we need to see during the surgery is that we need to preserve this recurrent laryngeal nerve. That's why there is important triangle which is found by the carotid artery here, inferior thyroid artery here, and recurrent laryngeal nerve. Okay, so this is that triangle. This triangle is known as Bayes triangle. Okay, it is written here, Bayes triangle. So Bayes triangle is an anatomical landmark for identification of recurrent laryngeal nerve, and recurrent laryngeal nerve is forming a boundary of Bayes triangle. You can see here again. One more important triangle is here, that is Joul's triangle. Okay, it is Joul's. That is found by, you can see, this is the midline of the neck. This is the superior pole of the thyroid gland, and these are the strap muscles. These are the strap muscles. So this forms a triangle, and this external laryngeal nerve is not a boundary. It is the content of this Joul's triangle. And the floor there will be cricothyroid muscle, and the external laryngeal nerve will be running in the triangle. It is not forming the boundary. Boundary is the midline, the superior pole of the thyroid, and the strap muscles. So this Bayes and Joul's triangle are important landmarks in identification of these two important nerves. And as I said, that suppose this is the main trunk. We don't ligate the main trunk. See, this is the main trunk. We ligate individually these vessels which are entering in the thyroid parenchyma. Okay, so as you can see, individual ligation of the vessel is done. We don't ligate the main trunk is preserved. We just ligate those vessels which are entering directly into the thyroid parenchyma. Okay, see, otherwise the post-op complications, there can be hematoma, and you can see if there is hematoma, it can compress the trachea, and patient can have respiratory obstruction or stridor in the post-op period, for which you need to immediately open up the wound, otherwise the patient can die also. Okay, so this is how a post-op hematoma looks, and the moment you open, the hematoma comes out, and the patient dramatically they improve. That's why most of the time these days when people they do thyroidectomy, they put a drain inside, so that whatever collection is there, it will come out, it should come out. Tracheomalacia is another problem. Hypocalcemia can occur because of parathyroid insufficiency, either due to removal or due to ischemia, and this is the carpopedal spasm which you can get in case of hypocalcemia. Vostek sign you can see when there is hypocalcemia. Okay, tapping at the facial nerve, there will be twitching of the facial muscle. Spongiform, because spongiform means it is more of a cystic lesion, just few areas of solid. So that's why the chances of malignancies are most in a solid lesion, and as the lesion becomes less solid, the chances of malignancies are less. So that's why we have taken the cutoff as 2 cm in spongiform. Spongiform is more towards cystic than towards solid, so that's why it is 2 cm. Okay, so this is about solitary thyroid nodule. Now if you have any question related to this solitary thyroid nodule, you are most welcome to ask, or anything which you did not understand, then I'll be happy to tell you those things again. Okay, one of the very important topics, solitary thyroid nodule. Yes, this is a demo class. There will be more demo classes. We'll take more important topics which are, we can say, sure shot, which are going to be asked in the exam. Okay, so no, radioactive iodine scan we don't do if we are suspecting a malignancy. As I said, if you are suspecting a malignancy, there is no role of radioiodine scan. We'll do the surgery, and in the follow-up period, we'll do the radioiodine scan just to see that if there is any residual tumor anywhere in the body in the form of the primary site or in the form of a lymph node or maybe some distant metastasis. So that is why radioiodine scan is done for malignancy, not for the diagnosis. And in highly suspicious also, we don't have to go for a radioiodine scan before the surgery. Go ahead, do surgery, and later on you can do this. Bayes triangle, okay. See, this is carotid artery. Okay, this is carotid. This is inferior thyroid, and this is recurrent laryngeal nerve. Okay, so this is that triangle. This is recurrent laryngeal nerve. So that forms a triangle slightly lateral, like recurrent laryngeal nerve. You will see when you do a retraction of the you can say the lateral most part of the thyroid towards medially. So when you retract, like this is the retracted thyroid gland, retracted medially. So when you retract it medially, then you have to search for this recurrent laryngeal nerve. So this is a very important thing, that you search for recurrent laryngeal nerve and then you keep it preserved and you can remove the thyroid gland. Okay, so that is Bayes triangle. Okay, so last 5 minutes, let's talk about, see, this is, we are talking about the ultimate live course. This is on eMedico's app. Okay, so those who are already in DAMS, you don't need, but you can tell your friends, your juniors, your seniors, those who cannot join these face-to-face classes or the TND session on the VSET. This app is basically for those people, okay, who are like working also, or who have not access to the classroom. So this is a very good option for those people. Okay, all the 19 subjects will be covered like we cover in case of like in the face-to-face classes or VSET classes. There will be live chat, okay, like what we are doing now. Otherwise, most of the apps you have seen, it will be a recorded session. So it will not be a recorded session. It will be live session, and we can do chat. You can ask questions. We can tell us. We can tell you. So this is the most important thing, that it is a live class. Okay, and the teaching hours will be almost same as it is. You can say same or maybe more than what you get on the live classes, face-to-face classes. Okay, 30 plus weeks, more than 30 weeks will be live teaching duration. Most of the time, because we know that these are the people, they are working in the hospital, so they might not get time in the morning or they cannot take off. So this will be a weekdays classes and in the evening. Okay, so you come back at 4 o'clock, you rest, and then from 5 o'clock most of the times the class will be from 5 to 9, so they can easily attend in their phone, in their whatever device they have, they can attend. And suppose they, if they miss any session, they can ask the videos again from the coordinator. They can ask that, okay, these are the sessions they have missed, so you will get the recorded session again. Okay, in that, if you have missed the lecture, you can get the recorded session. And in this course, these things are also included. DVT session, which you know that this is a very useful session, and there are lots of questions comes directly from the DVT in the exams. In the recently INI-CET exam, there were lots of questions from this directly. There will be a doubt solving session also, lots of doubt solving sessions. So if you have any doubt, you can ask. Like again, it will be a live session. You can ask. Test will be taken, and you will get the ranking with the rest of the students also, for those students who are joining the face-to-face classes or VSET class. There will be a all India ranking in that. Subject-wise test, and there will be, you will get the video solution, like the test will be discussed in the form of a video. Grand test also, grand tests which are very important. DAMS question bank, DQB online. So this is also, and this time we have included these clinical based questions, image based questions, which are going to be the pattern in the upcoming exams. Okay, and another concept book you will get with video companion. So there are lots of things you are getting on this live, you can say, ultimate live course. So this is all about today's session. I hope you have learned something. And thank you very much. TYRETS is for ultrasound. For MRI, there is something known as PYRETS, that is for prostate. Okay, so for prostate, we go for PYRETS. Okay, MRI has not much role in case of thyroid. Okay, there is nothing much you will get on MRI in thyroid, so that's why it is not very popular. Okay, so this is about the app. Now you can get a 10% discount on this app if you put the referral code, and if you put my referral code, you'll get this 10% discount. The referral code is DRGAMD029. Okay, this is my referral code. So you can put this code and you'll get 10% discount. So this was about the today's session, and thank you very much. I hope you enjoyed, you learned something new. and these are the very important questions. Okay, so you can ask me, if you have any doubt regarding anything in the surgery, you can always tag me on our Facebook club. Okay, so thank you very much and good luck for your exam. And if you have like your friends or seniors, juniors who are willing to join this course, and they are most welcome for this. Okay, thank you very much.